And now that brings us to our last, not panel, I guess we call it virtual fireside chat. I'm very pleased to welcome Scott Gottlieb, Senior Fellow at the American Enterprise Institute, and involved in a lot of other things as well. He was the 23rd Commissioner of the Food and Drug Administration until 2019. So there for an important period in the FDA. And that was after several previous roles at FDA going back to 2002, I think, when he was about 12. Now at AEI, he's continuing to do a lot of work related to drug innovation and medical product innovation more generally, but also public health and a lot of work on infectious disease. Maybe you may know him from his extensive efforts around not just COVID, but other infectious disease threats that have arisen since then. And Scott, we've already talked today about mpox, about measles threats, and about other resurging infectious diseases, as well as potential emerging ones, and trying to combine that with, on the one hand, technologies that are good, not only for protecting individuals, but potentially for reducing spread, vaccines that can help, therapeutics that can help, diagnostics that can help, better ways of and better opportunities to develop evidence on these products and to support their development and use, but also some challenges with, despite this progress and resurgence in infectious diseases happening. And I've been talking a lot recently about some of these current infectious disease threats. I'm wondering if we could maybe start with one that's been in the news a lot lately, the recent measles outbreak, where we've gotten some more evidence that I don't think we really needed, that there are indirect population effects when the use of vaccines fall. With measles, you have to get to a pretty high level, very high level of vaccine use to get to herd immunity. But I really appreciate your thoughts on where things stand now, this overall context into which these opportunities and challenges for reducing the burden of infectious disease can best address these recent trends.
Yeah, when I was 12 and I first joined FDA, I was fortunate that the standards were a little bit lower, and the commissioner at that time was a little bit more
Yeah, I
accommodating
know,
to
couldn't let
youth.
anybody in, right?
So yeah, everyone could get a job back then. Um, Look, what's happening in West Texas and other parts of the Southwest is deeply concerning. I think that just to level set, we probably have a lot more cases than what's being officially reported. Certainly, you get that impression when you talk to officials who are on the ground and some people at CDC. And if you just sort of extrapolate from the fact that we have two deaths in the setting of this outbreak right now and some very sick people who are hospitalized, if you believe the case fatality rate, which I think most people do, is about 1 in 1,000. Certainly, you would impute from two deaths that there are more than 300 cases and maybe upwards of thousands of cases. And one of the fatalities was a person who was in the home who never presented at all. And I think that gives some indication of the fact that people are getting sick and not presenting.
Not taking
So
care.
this outbreak could get larger before it gets smaller. Um, yeah, the concerning thing is that we look at the overall vaccination rates in the US right now, hovering slightly above 90% for MMR, which is well below herd immunity. But that masks the fact that you don't have uniform coverage across the country. And so states where the vaccination rates are in the high 80s and some states are in the low 80s, there's pockets in those states where the vaccination rate is significantly below that. And we're looking at state-based averages and national averages. But when the infection gets into these pockets of significant under-vaccination, there's probably communities that are in the 70s. If you're looking at a state that's in the 80% range or 85% range, that's sufficiently low that when the vaccine gets into that community, it's going to spread pretty quickly. And I think that this is, getting to the point of some of the discussion earlier. I think that this is sort of a secular trend now that's going to be hard to reverse, and certainly the continued dialogue around vaccines generally is to discourage parents from getting the kids vaccinated. The recent comments about cod liver oil and vitamin A, and steroids being perhaps therapeutically useful in the setting of measles, which just isn't the case. Uh, further reinforces for some parents who might be considering getting their kids vaccinated that, well, perhaps is a therapeutic, and they may, tip that sort of equation in favor of not getting their kid vaccinated, thinking that there's a therapeutic available in the same way that some people may forego flu vaccination or COVID vaccination, recognizing that Tamiflu is available and Paxlovid is available. And I'll mention I'm on the board of Pfizer.
Mhm.
There you can argue that's not a completely irrational decision for someone who's otherwise at low risk for going vaccination on a premise that there's an active therapeutic available. It's not something that I would counsel, but it's a decision that some people will choose to make. And in that case, there is a therapeutic available that could help rescue people who become infected and become ill. Um, but for this disease, there is no therapeutic available. And so I think that
Right.
you're going to continue to see downward pressure on vaccination rates. And this is not something that's going to be easily reversed. I think that the um, the ability to influence people's decisions and educate them about the pros and cons of vaccination is going to happen at a community level. I don't think the national dialogue is going to change. And I also don't know that's the most effective place to be having these conversations. I think there's a lot more that state-based and local-based health authorities could be doing to help address some of this vaccine hesitancy that we're seeing and are doing. But I think that's where the action's going to be, and that's where the most effective action can be.
And can the emphasis on community level fits a lot with what we've talked about today, where there, for example, is good evidence that vaccination use can reduce spread in people that come into contact, people in the community. You mentioned that measles, measles, we don't have great early diagnostics when people are transmitting a lot before they're really symptomatic. We don't have great treatments. In other infectious diseases, we do. For all of this, though, in order to, what are the best ways to engage communities? Because that's kind of what's needed to partner with the range of technologies that are available, whether it's vaccines, therapeutics, diagnostics, and ones that I think you'd see more development and uptake for if there was clearer evidence about impacts at the community level. You've been involved in a number of efforts to improve the data on surveillance. We wrote a paper together about things that CDC and CMS might do to make better data on infectious disease threats available locally. What kind of evidence could better engage and better support those local community-based efforts?
Well, I think certainly educating people about their individual risk continues to be important. And it's not just people who are unvaccinated, but even people who, you know, might choose to get vaccinated but not complete the series, or get one child vaccinated, not another. And a lot of these children who are most vulnerable and getting infected are in households where you have young parents, you have moms who are pregnant. Congenital measles is devastating. You have
Yeah.
other kids in the home who might not be able to get vaccinated at all and would be very vulnerable, newborns, young babies. And we saw the recent case where a woman who had measles went into a maternity ward to deliver, and now all those newborns in that setting were exposed to measles and they're excessively vulnerable. So I think, educating people about that individual risk. But I also think at a community level, it's easier to have the discussion about the collective risk. At a national level, the idea of collective, the collective good of vaccination feels kind of remote. But when you're at a community level and you're, going to school with your neighbors and seeing other children in a class who might be more vulnerable than others to measles, or young moms who have infants who want to protect their children, but then some parents are choosing not to protect their children, and they may be importing the vaccine into that environment where maybe a young mom's pregnant, maybe a young mom has a newborn at home who can't get vaccinated, and now that child who chose not, the parents who chose not to vaccinate their child are putting at risk that family. I think that appeal to sort of collective action to help your neighbors and help protect your community is much more resonant if you're advancing those arguments at the level of the community. And that's why I think sort of community-based efforts to try to promote vaccination are far more effective than national efforts, because at a national level it feels kind of remote, and people might be more likely to adopt the view, well, I'm not getting my kids vaccinated, but everyone else is getting their kids vaccinated, so I'm not going to be putting at risk everyone else's kids. That's not the case. And I think trying to bring home that argument and pull it through is important. It's important to do it with data, and I think it's much more effective at a community level, where you could actually model out what the risk is going to be to how many, young families there are with kids just who, even if they choose to get vaccinated, aren't at an age where they can get vaccinated, or maybe are at a point where they got one dose but haven't gotten two. And we've seen 4 kids in the setting of this measles outbreak who were vaccinated, who got measles, and they were likely kids who got one dose of the vaccine. So, these kinds of realities at a community level, I think, are much more resonant to people who, I think will be swayed by the argument that you need to take collective action to protect people that you go to school with and you shop with and you live next door to. And that's why I think the argument's much more effective at that, going to be much more effective at that level.
What are the best ways to, you think, to empower those kinds of effective community-based efforts to share information, pull together? We've seen examples around the country, a lot of them of leaders of healthcare organizations or business leaders who have spoken up about the available evidence. We've worked with, or you've worked with people like Caitlin Rivers, who are trying to develop better data systems that can be used locally, kind of the weather report related to infectious disease risk in a community. What do you think would be, kind of connecting, especially better data to these efforts? What are the best ways to support them?
Yeah, well, it's the qualitative arguments that we've sort of outlined here, but it's also getting to your point, the quantitative arguments, and I think trying to look at data at a community level, and trying to model what the impact could be to a community when you fall below a certain vaccination rate, and there are people who come down with measles in the community, and what the risk is to the community. We don't have really good data sets, or they haven't been extrapolated or extracted from in a way where you can make an argument about the risk of spread within this particular community. And even stepping back from West Texas, where I think the risk is now apparent, just looking at other communities where vaccination rate levels may be 80%, I think it still feels remote. People don't understand what it means for a community to get to a vaccination rate of 80%, and what is the risk to young children and toddlers in that community who either can't get vaccinated or only have one dose of the vaccine and want to
Yeah.
be protected, maybe have to be protected because they're even more vulnerable than the average child. And in what it would mean if someone who's chose to be unvaccinated imported the virus into that setting, into a school setting where, vaccination rates might be 80, 85%. It doesn't feel like that one child who makes the one introduction can put the entire community at risk, but in fact, that's the case. And I think we haven't really modeled that well and explained that risk well. And I think if we did that, it would be much more tangible for individuals who are making that
Yeah.
decision to forego vaccination. So, I would try to take the national level data that we have and the state-based data we have and really extrapolate it to what it means in a community setting when you fall below a vaccination rate, overall vaccination rate of 85%, what it means to the community, how many newborns are in that setting, how many pregnant moms are in that setting who now could be put at excessive risk because of the decisions that other people made. And I think again, at a community-based level, people people do things to protect their community, right? So, it feels much more direct, and no one wants to be
Yeah.
that outlier family that were the ones who introduced that risk to others. So those are the kinds of arguments I would be making. I think to the extent that we could support it with data and what the transmission dynamics would be like in that setting, the more convincing it's going to be. So I would be trying to go into those communities with low vaccination rates.
Local
Look at a
data
state,
yeah.
yeah, look at a state that's at 85%, and then pull out from that what are the communities that are far below that are at excessive risk, and try to go into those communities and educate people around what that risk means.
To complement that, is there any point in getting more evidence on vaccine and other medical products safety, effectiveness in for both individuals and for people around them? We talked earlier with Peter Marks, who described the FDA's best system for tracking vaccine use and associated adverse events and also health benefits for individuals and even people around them. How we're getting to the point where, for many communities, we've got pretty good data from lab reports and health systems on uptake of vaccines, also testing, other steps that show how well a community is responding locally. Do those additional data sources also help, or do we just need to keep it simple at this point?
Oh, look, I think those data sources help. I think if I was in a policymaking seat now trying to influence this debate, what I would be looking to do would be to take some of the data collection schemes that we currently have, find ways to augment them, because you can always do things to improve data collection, and then kind of relaunch it, rebrand them, because there is this sense, and I don't think we're going to fully sort of refute this notion that we don't do enough to collect vaccine safety information. There's this whole trove of safety information that's been kept from public view. All these kind of inaccurate perceptions, and you continue to see sort of rhetoric and dialogue that reinforces this view. And as much as you want to push back against that and sort of re-educate people and say, no, no, look, we've been collecting all this data all along. It's available. It's transparent. I don't think you're ever going to fully win that fight. And so what I would be doing if I was running FDA now, or running a public health agency, is finding ways to kind of relaunch what you do. And it's not just a rebranding campaign. I think in the context of it, but it's partly a rebranding campaign. But I think in the context of a rebranding campaign, you can look at ways to try to expand the footprint of what we're doing to collect information, make it available to consumers, find more seamless ways to make it available, um, more interactive ways to make it available, more ways to interrogate it at a community-based level. So local reporters can also extract the information and write local stories based on the local risk. But it also is a rebranding exercise, and there's some virtue in that. I think both you and I have been engaged in those kinds of exercises in the past as a way to kind of reinstill public confidence in what public health agencies were doing. And there's nothing wrong with that, especially if it's done in the context of actually trying to improve the data collection, the data delivery. And I think, the data delivery, particularly at community level, could be really, really impactful, because then it creates a much more realistic perception among consumers that the information truly is available. Because when they're looking at national averages and state level data, it doesn't feel like it's real information in a way. But if they're looking at information that talks about their specific community, and we had this for COVID, right? So we know
Mm.
we can do
Yeah.
this. We created heat maps, and you had data right down to local hospital admissions and local transmission dynamics. And so we know we can do this. We just haven't done it for things like measles. And this would be I think measles in particular would be a good place to start if we were going to try to do this around some of the routine pediatric immunizations.
Well, it doesn't have to be just about measles or just about what's in the headlines, but as we were talking about in the last session, these risks of infectious diseases are ongoing. The data capabilities are getting better, and it sure seems like a worthwhile step at this point to try to strengthen their connection to local communities. We have assuming the Senate gets busy next week, perhaps a new FDA commissioner very soon who could take some of this on. Any other advice for him along these lines?
And partnering with local health plans,
Yeah.
partnering with local and state officials, partnering with local health plans and local healthcare providers and institutions. I think they would be really interested in getting engaged more in data collection and trying to promulgate some of this information back to their local communities. If I was sitting there, I would be looking at a couple of communities that you can extract to try to you know, um, test some different kinds of approaches. Pilot project, 10 or 15 communities, make it small enough so you're not boiling the ocean, and try to develop some of these local models for data collection and data distribution. Again, partnering with some of the local healthcare entities. I think that there would be a lot of uptake for that among the healthcare providers in communities. And you can, in the context of doing that, pilot some models that you could then try to encapsulate in more of a federal effort.
And learn more about what does
Right.
make a difference, and maybe even some other steps beyond vaccines
Right.
that
And it's easier to
you
do
maybe
measurement at
could
that
help.
level too. So you can
Yeah.
see what influence you're having on consumer perceptions.
Yeah, and help maintain. We talked about this a lot today too. Getting past and recognizing some of the limitations of data, addressing them, and getting to again good evidence-based local policy. I want to end up on one. It's been a great discussion about just how important communication is and just how important local, reliable, timely data is to support that, and a lot of potential now more than ever. We are seeing the downward trends, though, in vaccinations. There are, as you know, a lot of products in development that potentially could do a better job, not only in reducing the serious infections in individuals who use the product, but maybe in reducing transmission. We had some discussions earlier around vaccines with different modes of administration or products that might activate other aspects of the immune system. There certainly have been, in the case of COVID, diagnostic tests that can be talked about those too for other conditions made more easily available at a lower cost. How do you see other technologies like next generation vaccines and diagnostics, therapeutics, maybe helping to offset some of the decline that we're seeing with vaccines alone?
I think that we've seen over the last 25 years a real resurgence in vaccine technology and investment in new vaccines. And I kind of date this back to the early 2000s when you were at FDA and we saw
Yeah.
new vaccine approvals like Gardasil. And suddenly this became a segment that was profitable to invest in again. We've seen blockbuster vaccines come onto the market. And so now there's a realization within the pharmaceutical industry that vaccines can be a profitable business and you can develop new IP. Because after all, a lot of these pediatric vaccines, DTaP, polio, MMR, are really commoditized. Prices have been driven down very low. They're not great businesses. They're not high margin businesses, but I think we've seen high margin products come into the market, and they'll eventually go generic and be available at lower prices too. And these prices get negotiated down because there's bulk purchasing and Medicaid programs and things like that. And so I think you're seeing a resurgence in investment. I'm worried that some of the kind of anti-vaccine sentiment is going to make people concerned about continuing to invest in these things, and some of that could pull back. There's only a small subset of companies that are fully invested in this space, and some startups, but it's very expensive to bring a vaccine through development in the context of a startup, and it's hard to fund in a venture capital syndicate. So this is sort of a fragile market. Um, you know, the the prospects are probably better for vaccines targeted to older populations, which value absolute efficacy, and I think have more awareness of the risks of infectious disease than younger populations, and that's where I think a lot of the development is going to be. But I think that this is to your point, to your fundamental point, I think this is a real opportunity, and we've seen a lot of innovation. I think that there's a real risk that you could see some pullback from those investments if this current trend around vaccines generally continues. And we'll see what happens to vaccination rates. I think the biggest risk right now that I see is that there could be a move to try to move things that are currently on the recommended schedule on the CDC's overall schedule away from recommended vaccines into the category that Gardasil sits in, where it's sort of joint decision making, where the recommendation is that the decision to take the vaccine should be a joint decision between the parents and the physician, which sounds very logical and appropriate. Everything should be a joint decision between the parents and the physician. But if you move vaccines into that schedule, and that's the schedule where Gardasil sits, it's more of an optional schedule versus the recommended vaccines, which end up being part of the school entrance requirements and are more of a mandate. And those are vaccines like
Not and maybe
polio and
not
DTaP and
reimbursement
MMR.
for that at
Right,
state, not
exactly.
primary care capacity,
Right.
which
And so I think that if I'm worried about what the next policy step by HHS could be, I worry that they're going to look to do that because it would align very cleanly with some of the rhetoric from and a dialogue from Secretary Kennedy, where he says, "Well, I don't want to take away your vaccines. I just want it to be a decision between physicians and parents." And well, that would mean moving all these vaccines into that other category. And so if I was looking into a crystal ball about what the next kind of policy step could be along the lines of what we've seen recently, that would be my concern that there would be a move to do that. And I think that if you think about decline in vaccination rates, my going in assessment would be this is going to be a slow erosion. But if things were to be moved off that recommended schedule, that could create a real inflection point where you see a real downward step in vaccination rates, because I think it would put pressure on a lot of state legislators to weaken the standards, weaken the requirements around school entrance requirements and school mandates, and that would really have a significant impact on things like MMR and DTaP and polio. And those are the ones I worry about the most, because those are the ones that are most dependent on sort of community level vaccination and the collective action that we talk about when we talk about herd immunity.
Well, important point to end on. This is a very important time from the standpoint of population health and infectious disease risks, and tying back to a couple of other topics we talked about today on the healthcare payment side. The administration has expressed a lot of interest in moving towards stronger primary care, stronger population health that in principle could use the data we've just talked about, could reinforce and provide a better capacity to engage the public than really stretched primary care providers have now. And then on the FDA side, a lot of it of opportunities to clarify and improve use of data, even locally. But that too is going to depend on, and a lot of ways to engage product developers who may be feeling a little uncertain right now, even though the technology opportunities seem better than ever. But you're going to need a strong FDA staff that can engage effectively on this under strong leadership at the agency. So,
Yeah, and FDA,
yes.
FDA has been very, I think, adept at taking existing systems, reinvigorating them, modernizing them, and sort of relaunching them and rebranding them in ways that they resonate more with consumers. And that's what I'd be looking to do here with some of the data collection schemes that we have in place, make them more robust and refashion them to kind of conform with what people's expectations are right now.
All right. Really important times. Thanks for being here, Scott. I know it's been a long day for you for this very timely and relevant discussion to infectious disease burden and
And
hopefully a
and
healthier
thanks
future.
thanks for taking a chance on me when I was 12, Mark. I'm grateful for the opportunity you gave me.
Great. Well, somehow I think this is not the last time we'll be hearing from you.